We looked at the Hep C life cycle and mechanism of action of antiviral agents. We looked at AASLD recommendations for treatment of Hep C, and we evaluated drug-drug interactions. Now the next learning objective is given an Hep C patient, design an individualized monitoring plan. Now, there is monitoring that needs to be done prior to starting antiviral therapy, and then there is monitoring during antiviral therapy, and finally monitoring after the end of antiviral therapy. Now, let's take a look at what we need to monitor before we actually start antiviral treatment for patients with hepatitis C. So obviously we need Hep C genotype and subtype only if using a non-pangenotypic direct acting agent. So for example, if we are using Harvoni, we need to know for sure that it's genotype 1 because Harvoni will not be appropriate for genotype 2 or 3. Whereas if you're using something like Epclusa, because it covers all genotypes, it's unnecessary to actually get genotype. As long as you know the patient is diagnosed without knowing the subtype, that's sufficient to go ahead and start. Now, what we do need for all patients is to get a quantitative RNA viral load at baseline. So before we start, we need to know how much RNA is in the system, because that's how we can monitor to see if the treatment is actually working. Because once we start treatment, we want to see a drop quantitatively in the RNA viremia. And then we also need to screen the patients for HIV and Hep B. With HIV, obviously because the same risk factors that expose the patients to hepatitis C can also expose them to HIV. But Hep B is particularly important to be screened, and we use the surface antigen. And we use the Hep B surface antigen, anti-Hep B core antibody, as well as total anti-Hep B surface antibodies. These all come from the Hep B panel. And the reason this is extremely important is because there have been cases with people who did not know they have Hep B. And once we started treating hepatitis C, then there was a reactivation of hepatitis B, which actually resulted in patients dying. So in fact, the FDA has put a black box warning in the stating that Hep B virus reactivation has been reported, in some cases resulting in fulminant hepatitis, hepatic failure, and death. And if someone does test positive for hepatitis B, it is not a contraindication for treatment of hepatitis C. It's just that we need to evaluate the patient for hepatitis B treatment. And if treatment of Hep B is indicated based on the criteria in the 2018 AASLD guidelines for chronic hepatitis B, then it should occur at the same time or before starting Hep C. So either start the treatment for Hep B and later on treat the patient with Hep C, or you can start them at the same time. What you do not want to do if the patient qualifies for Hep B treatment, to start Hep C treatment before starting Hep B treatment because of this black box warning, which can be deadly. Now, if the patient does not qualify for Hep B treatment, it is important to monitor the Hep B DNA at baseline and every 4 weeks, just to make sure that as soon as the patient qualifies for treatment of Hep B, then they should receive Hep B, even if it's during Hep C treatment. And in fact, Hep B treatment, once it's started, it should continue at least until 12 weeks after completion of Hep C, just to make sure that this reactivation doesn't occur. Now, other things that we need to monitor before we start Hep C treatment is we need to evaluate patients for drug-drug interactions with medications that they are currently on. So that's important, and sometimes that can guide us to which Hep C regimen to choose to avoid drug interactions. It is important to check patients' baseline hepatic function, and we can use a hepatic function panel that includes albumin, bilirubin, ALT, AST, and alkaline phosphatase. And we also need to assess the renal function, so the GFR, and these can be within the previous 3 to 6 months. Now, if someone who's otherwise healthy, it can be within 6 months. Someone with cirrhosis, for example, needs to be in the previous 3 months. We also need to check CBC and INR in the previous 3 to 6 months. And depending on the regimen that we are about to start, we may need to get a baseline RAS or resistance associated substitution. And specifically, if we're using elbasvir, grazoprevir for genotype 1A, or if we're using sofosbuvir, velpatasvir for genotype 3, we need to get the baseline RAS before we initiate treatment. Otherwise, if we're using anything else, then this RAS is unnecessary. Now, once we start treatment, during treatment, we want to have clinic visits or at least telephone contact with the patients. And this is to assess adherence. We want to make sure we talk to the patient, make sure they've been taking their medications and they're not skipping doses. Every dose counts. And we want to assess for adverse effects. So, we want to ask the patient and see what adverse effects they're having. Sometimes they may stop taking because of these adverse effects. And sometimes they may take this and these adverse effects might be something that we can manage. And of course, we need to talk to the patients about new drug-drug interactions. So if there's, because treatment of Hep C is pretty much, over 3 months for many patients, or 8 to 12 weeks for most patients, they may start a new treatment. So let's say if they get an infection, or at any time someone could take like supplements or over-the-counter medication. So it's important to routinely talk to the patients and assess new drug-drug interactions. And these patients typically follow up in the in specialized clinics, so in the ambulatory care setting where pharmacists can get one-on-one time with the patient. So this will typically be done in the ambulatory care setting as opposed to community setting. In the community setting, specialty pharmacies are involved with hepatitis C, and the patients can be managed by those pharmacists as well. Now, for diabetic patients specifically, it's important to monitor for hypoglycemia, because there have been reports of once Hep C treatment started, these patients had more frequent hypoglycemia. Hepatic function panel during treatment is important in cirrhotic patients. Otherwise, if the patient is non-cirrhotic, this is really unnecessary unless the patient is taking protease inhibitors. And because protease inhibitors, specifically act on the liver, it's important to get the hepatic function after 8 weeks just to make sure that, the ALT is not increasing or the patient is not symptomatic. If there is a 10-fold increase of ALT, or even if it's less than 10-fold, but the patient has symptoms of hepatic failure, it is important to discontinue treatment immediately. Now, once the treatment is complete, it is important to get the Hep C viral load at least 12 weeks after completion of treatment. So once the patient takes the very last dose, they need to come back 12 weeks later, and we're gonna get the Hep C viral load. And if it's negative, that's when we're going to claim a cure or SVR 12, and we know the treatment has been successful. Otherwise, if it's detectable 12 weeks later, it could be either treatment failure, or if the patient has had risky behavior, it could potentially be reinfection. That's a totally new infection.